Brings us to hemostasis. Okay? Hemostasis. Keeping the blood in the body. Okay? Keeping the blood in the body. So this is not a misspelling of homeostasis. New word. Keeping the blood in the body. If you get a leak and it doesn't stop, all of your blood will end up on the floor and you will die. What a surprise, right? Luckily for us, we have mechanisms to keep the blood in the body, right? So these mechanisms we're going to talk about are involved in hemostasis, keeping the blood in the body. The very first of these phases is something that we call vasoconstriction. Okay? Vasoconstriction. So that when you start to get a leak, those of you who have lab, you stuck your fingers on Monday, right? So when you start to get this leak, platelets are going to adhere to the rough edges of the inside of the vessels, and when the platelets adhere, they're going to release some platelet factors that help in coagulation, but they also cause vasoconstriction. And it turns out that inside our platelets, we have epinephrine, serotonin, and a prostaglandin called Thromboxane A-2. I think this is pretty cool, right? Your platelets have serotonin and epinephrine in them. I thought those were supposed to be neurotransmitters, but they're found in your platelets. Right? So in your platelets, you have these chemicals, serotonin and epinephrine, to help cause constriction of your blood vessels, along with this prostaglandin, Thromboxane A-2. And so they're just trying to show a simple, right, constricted blood vessel. But when you stuck your finger with that lancet in lab, the first thing that happened is platelets began to adhere, they released these chemicals, and they tried to constrict the blood vessels to slow the loss of blood. Wouldn't it be nice if you had a tire that worked that way, or a radiator hose in your car that worked that way, right? As soon as you got the leak, it would start to constrict to stop the leak, right? This is our first step, vasoconstriction. The next step in hemostasis is something that we call platelet plug formation. Okay? Platelet plug formation. So this diagram is trying to show you the nice smooth lining inside the blood vessels, right inside the capillary. And then here's where damage has occurred. But as that damage occurred and collagen was exposed underneath the nice smooth endothelium, the platelets began to adhere. Right? So the platelets begin to adhere to those rough edges. And when the platelets begin to adhere, they're going to release their chemicals we just talked about, epinephrine, serotonin, thromboxane A-2, and also ADP. ADP? What the heck is that? Oh, adenosine diphosphate. So your platelets actually have high levels of ADP that can be released, and ADP and thromboxane A-2 make this area, make the platelets and the area of the collagen very, very sticky, so that more platelets begin to adhere to try to plug the leak. Okay, and so they're trying to show here, right? The leak gets plugged, in this case, by the platelets. And that happens all the time. Okay, so you get little leaks, the platelets plug up that hole, and you move on, right? You'll do repair a little bit later that we'll talk about, but you plug that up. Well, the third phase is the one that you hear most about, coagulation. All right? So this is the clotting part, the coagulation that you're used to hearing about. Coagulation involves 12 different clotting factors. We're going to learn some of them. We're not going to learn all of them, but we're going to learn some of them. And so this is a nice electron micrograph trying to show red blood cells, but all these nice, really big fibers in there that form the clot, right? So this is lots and lots of fibrin that has closed off the leak. You've been able to form a clot. It turns out that when we look at coagulation, there are two different schemes, okay? Two different pathways that we can get a clot to form. Here's the end result that we want. We want this fibrin, really this fibrin polymer, where we have those nice fibers that are formed. But there are two different ways that we can get down to that fibrin. One of these pathways is something that we call the intrinsic pathway. The other pathway is something that we call the extrinsic pathway. Intrinsic means comes from within, and that's referring to it's going to come from within the blood. Extrinsic means it comes from outside the blood, and really it's going to begin in the tissues. Let's look at the intrinsic scheme first, and then we'll come back to the extrinsic scheme, which is quite a bit simpler. Now, when I was in school, I know I say that way too much. When I was in school, I had to learn all the names of these clotting factors. The reality is, these days, most people just learn the Roman numerals. And so, if you'd like to learn the names, you can, but I'll make it easy for you, and you can just learn the Roman numerals for the different clotting factors, right? So there are going to be 12 different clotting factors. Turns out that there are, it's a little strange, but there are 13 different numbers because one of the clotting factors ended up being named twice. They got confused and didn't know that it was the same clotting factor. But so here we go. We're going to start up here on this intrinsic pathway. It says that the activator is collagen, glass, or other things. Well, glass meaning if you poured the blood in the glass tube. We don't care about that. Normally this is going to start by exposure to collagen in your blood vessels, right? So it's going to start there, and platelets are going to adhere and release their clotting factors. And when they release their clotting factors, they're going to activate the first in this intrinsic scheme, which is factor 12. It happens to be named Hageman factor. I don't care that you know Hageman factor, but it's factor 12 is activated. This is already, this clotting factor, most of these are already in your plasma, floating around, but they have to be activated, right? So they're in there, they have to be activated. So once factor 12 is activated, it's going to activate factor 11. Okay? It's going to activate factor 11, which is something called plasma, I'm supposed to remember I can't remember my PTA right now.
Parent-Teacher Association.
Tissue antecedent. Plasminogen Thrombin.
Google it.
No, I'll look up my notes. I'm not going to Google it, but it's amazing. It's amazing that my brain just went on the fritz.
Happens to me all the time when I'm taking one of your quizzes.
That's all right. My brain just fritzed on it. Plasma, thromboplastin, antecedent. Plasma, thromboplastin, antecedent, PTA. The next one that's activated is plasma thromboplastin component, factor 9. Once factor 9 is activated, it's going to work with a number of clotting factors that we're not going to learn, but I would like you to know one of them, factor 8, which is called the antihemophiliac factor. That's going to become important to us, right? The antihemophiliac factor and calcium. Okay, so once factor 9 is activated, plasma thromboplastin component, you don't need to know the name. Once it's activated, it will work with factor 8, the antihemophiliac factor, and calcium to activate factor 10, which is called the Stuart-Prower factor. Again, I don't care that you know those names. Once factor 10 is activated, it's going to work with calcium and other clotting factors to activate prothrombin. Now, prothrombin, I would like you to know the name of, right? So this is a common clotting factor that people need to know. Prothrombin happens to be factor 2. But once prothrombin is activated, prothrombin is going to change into thrombin. Prothrombin is produced by your liver, as are most of these clotting factors, but prothrombin is produced by the liver only if there's adequate amounts of a particular vitamin around. What vitamin is required for clotting?
K.
K. right? So you need vitamin K so that your liver can make prothrombin. Once prothrombin is changed into thrombin, it's going to work on a clotting factor called fibrinogen. I'd like you to know that name. Fibrinogen happens to be clotting factor 1. And fibrinogen, in anatomy, did you learn that term ogen? No? If you see ogen, it means a precursor to. So fibrinogen is going to become fibrin. Right? Fibrinogen will become fibrin, and fibrin actually happens to be clotting factor 13. I don't care that you know that number, and forms this fibrin polymer. Okay, so this is the intrinsic pathway that's activated typically from coming from within the blood. Right? So you've had damage to the collagen, platelets adhere, and this starts this whole process. There is an extrinsic pathway, right, that comes from outside. When you stuck your finger with the lancet, not only did you poke a hole into the blood vessels, but you damaged tissues around the blood vessels. And when you damage those tissues, you release a chemical called tissue thromboplastin, which can start the extrinsic scheme. Okay, so we're going to start an extrinsic scheme. They can both run simultaneously. Okay. Tissue thromboplastin, when it's activated, it's factor 3. And if you want to just know factor 3, I'm okay with that. It's going to activate factor 7, which is called proconvertin. You don't need to know proconvertin. Okay? It's factor 7. Factor 7 will work with other clotting factors and calcium again and activate factor 10. Stuart-Prower, and now we're back into the common pathway. All right? Yes?
So, back to vasoconstriction. It has to follow those 3 steps, and then the last step is the clotting pathways, like for every situation, or is it different?
You know, they're going to happen almost simultaneously, but the very first thing that's going to happen is platelets are going to start to adhere to that exposed collagen. And when they adhere, what's the next thing that's going to happen? They're going to release their platelet factors. That's going to cause vasoconstriction. The clotting is going to come later. Right? But they happen very quickly, all of these things. We can separate these two, right? I could take some of your blood and put a needle into a blood vessel, suck out some of the blood, put it into a glass tube, and the only thing that's going to happen would be the intrinsic scheme. Make sense? Because we wouldn't have any tissue damage releasing the tissue thromboplastin. Okay, so 2 different schemes. All right. So you damaged your fingers in lab, right? You poked your fingers with that lancet. What about tissue repair? We're not going to always have a clot that's clotted up that area. We want to repair that. And so fibroblasts are going to be attracted into that area to start building new tissue, right? They'll come in and start building new tissue. And you're going to produce an enzyme called plasmin that will eventually break down the clot. Okay? We're going to produce this enzyme called plasmin to break the clot down. You had to clot that vessel up, but you don't want to leave it clotted forever. So we're going to have this enzyme plasmin produced, and it's going to be produced by something called plasminogen. Well, we just learned that ogen means precursor to that, right? Plasminogen produced by the liver as well. And it turns out that you have a chemical in your tissues called tissue plasminogen activator. Okay? Tissue plasminogen activator, TPA. Okay? Tissue plasminogen activator, TPA. And that chemical, tissue plasminogen activator, will change plasminogen into plasmin and allow you to break down the clot. TPA, the gene for that chemical, was sequenced by Genentech years ago, and it is a drug that's available. Okay? So TPA is available, and it's a very important clot buster. It's a very important clot buster, as is another chemical that I don't have up there called streptokinase. Okay? So TPA and streptokinase are both clot busters. When we get to the cardiovascular system, right, we're on the system, but when we get to the heart, one of the things we're going to talk about is myocardial infarctions, heart attacks, and strokes. So when a person is having a stroke or a heart attack, that is the stroke most commonly caused by an abnormal clot, heart attacks caused by an abnormal clot, when that clot forms, blood does not flow beyond the clot and tissues begin to die. If we can get the person to the hospital and give them a clot buster, either TPA or streptokinase, that chemical will break down the clot and allow blood flow to return to the tissue, whether that's the brain or the heart, and so we can save the tissue. So, right, time is tissue, and these clot busters are critical for breaking down those clots. We'll talk about this more when we get to the cardiovascular system, but one of the real problems that we have is that people that are having heart attacks and strokes as well oftentimes are in denial, right? And I'm not talking about a river in Egypt, right? It's a major problem. So how is clotting normally prevented? We don't want blood to clot right now on us, right? We'll die. We'll have a stroke, blood won't be pumped, the heart will die if we all of a sudden form a clot. So we want to prevent clotting until it's time, and it turns out that the inside of your blood vessels is coated with a very smooth coat of endothelium so that platelets won't adhere. The endothelium also produces a chemical called prostacyclin, which tends to inhibit platelet aggregation. And we also have a constant release of heparin from, which of the white blood cells makes that? I know we just went by. The basophils. The basophils, right? So, and it turns out that heparin inhibits thrombin. So that normally we won't clot unless we need to. Of course, there's a very delicate balance there. Bleeding diseases. I have time. I think I can do hemophilia real quick here. So, phil, I said, means to like. What do hemophiliacs like? Blood. Right? Because they tend to leak. Right? So they need blood. It's really, hemophilia is a number of different diseases, but the one that we want to talk about is the classic type A hemophilia that's a sex-linked inherited disorder. So we've been through sex-linked inherited disorders already when we talked about color blindness. Works the same way. It's a recessive trait found on the X chromosome. And so here would be a carrier female that has the abnormal gene that says don't make factor VIII, the antihemophiliac factor. Right? So we know you have to have that factor VIII, that antihemophiliac factor, to do that intrinsic scheme. So she has one copy of the gene that says don't make that, but she has a normal gene on her other X that says yes, make factor VIII. So she can still clot. She marries a man, he has only one copy of the gene because it's found on the X chromosome, not on the Y. They marry, here's a normal female, here's a carrier female, here's a normal male, but here is a hemophiliac male. So the Y chromosome, right, ends up with that X chromosome. The Y doesn't have a copy of the normal gene, you end up with a hemophiliac male. So this is most commonly found in males. Statistically, we know that 1 in 100 million females would end up with this condition. Let's stop there. Quiz on Monday, folks, and we'll finish up blood, and we're going to move on. Finished. Right, so we learned that it's a sex link, and that these people can't produce factor 8. It's going to be primarily found in males, because the only way you can get a female is if you had a hemophiliac man and a carrier woman. Of course, prior to modern medicine, there was no way to get a hemophiliac to live a long life. These hemophiliacs, because they're missing factor 8, remember that factor 8 is in the intrinsic scheme, so they can still clot, but using the extrinsic scheme, right? So they're not going to clot as well as a normal person. We can give them clotting factors to keep them alive, and so people that have this type of hemophilia carry a syringe with clotting factors that they can inject if they begin to bleed. This type of hemophilia has affected world history, because the earliest that we can find this gene was actually in Queen Victoria of England. They're not sure if she actually had the mutation or if she got it inherited it. But the royal families of Europe in those days interbred a lot. And eventually the last Tsar and Tsarist of Russia ended up with only one male child. They had numerous female children, but only one male child, Alexis, and his father, of course, Nicholas and Alexandria, his mother. So they had only one male child who had hemophilia. And in those days, they didn't know about factor 8, of course, and sometimes he could clot, sometimes he wouldn't. They fell under the influence of a man by the name of Rasputin, and the rest, as they say, is history. Right? So kind of interesting, right? As they tried to keep him alive, maybe not spending as much time in governments as they could have. As I said, now we can give them factor 8 to carry with them. In the 1980s, when AIDS was just starting to spread throughout the world, they hadn't yet detected, or hadn't yet found ways to detect the AIDS virus. And in order to collect enough factor 8, they have to pool many units of blood. If they couldn't test for AIDS, you had hemophiliacs that would die if they didn't inject themselves, so they really didn't have much choice, right? But we ended up giving about 60% of the hemophiliacs in those days AIDS, because they couldn't detect the virus. Now, of course, they test for it. You can get, as I said, a female hemophiliac. Chances of that are about 1 in 100 million, right? Because then you have to have a carrier female find a hemophiliac male. So very, very small chance that that's going to occur. Another bleeding disease would be something called thrombocytopenia, decreased numbers of platelets. Right? A decreased number of platelets. They actually do have discovered the gene and now artificially produce a chemical, a drug called thrombopoietin. Not too hard to figure out what that one does. Right? Stimulates increased thrombocyte production. We learned that vitamin K is required for the liver to produce prothrombin, and so we can have decreased prothrombin levels. You can have decreased any clotting factor levels, but prothrombin levels can be decreased if there is a deficiency in vitamin K, or if the person has a liver disease. So for instance, what if they had cirrhosis of the liver? Then they're not going to be able to produce adequate amounts of prothrombin. Some coagulation tests. You're a surgical nurse. Wouldn't it be nice to know before the surgeon starts cutting on the patient if the patient's going to bleed out all over the floor? Right? It'd be good to know ahead of time. And so they have tests to find out if the person is going to be bleeding excessively. One of the easiest tests is something just called bleeding time, where they simply stick the earlobe or a finger and they time how long it takes for blood to clot. Right? Typically, you don't need to know this, but typically within 3 to 4 minutes, blood will clot. Unless you're taking physiology lab, in which case it clots about 30 seconds, right? You're trying to get the blood out. A more controlled test is something called clotting time, where they take the blood and in a controlled temperature, so that they put little tubes of the blood in a controlled temperature block with a little stirrer in it, and they can control the temperature and they can check exactly how long it takes for the blood to clot in the glass tube. So that would be called clotting time. And then another test that's been around for quite a long time is called prothrombin time. These days they tend to call it the INR, or International Normalized Ratio Test, the INR. So the idea here is, folks, that let's say that you have somebody that has a very slow clotting time, right? So they're very slow to clot, and you want to know why they're slow to clot. So what you can do is you can put a chemical in the blood that ties up all the calcium. We're going to find out those chemicals in a minute, I'll tell you. But you can tie up all the calcium. We know that blood can't clot without calcium, right? So the blood won't be able to clot. Now you have the blood in a tube, and then you can add to that tube all of the clotting factors, including calcium, except you won't add prothrombin. Okay? So here's the patient's blood. I'm putting all clotting factors in there, including calcium, but I'm not putting any prothrombin in. If the blood's going to clot, where does the prothrombin have to come from? The patient's blood, right? The patient will supply the blood, the prothrombin. They might be supplying the other clotting factors as well, but if the blood's going to clot, you've put in all the clotting factors except prothrombin, so if it's going to clot, their blood's going to have to supply the prothrombin. If it doesn't clot or clots very slowly, you know the problem is the patient has depressed prothrombin. You can do this with any of the clotting factors. So if the person has a bleeding disease, we can slowly but surely figure out which clotting factor is their problem. Right? Typically, it involves prothrombin, primarily because there are drugs that we use for the production of prothrombin. And so this is a common test. They call it the International Normalized Ratio. So they actually take a ratio of what the patient is to a normal ratio, and they report this.
I've heard throughout my life that alcoholic painkillers will prevent you from clotting.
Yeah, I don't know of an effect of alcohol, but aspirin is a very good prostaglandin inhibitor. And remember, we saw when we put those prostaglandins on, remember that there were prostaglandins that stopped platelet aggregation. That's why aspirin stops coagulation. I don't know of an effect if you have an alcoholic. They're going to have cirrhosis of the liver, but small amounts of alcohol, as far as I know, have no effect on clotting. So, some anticoagulants to prevent unwanted clotting. Really, we're going to look at two different possibilities here. In a living person, so in vivo, that means in a living person, and in vitro, that is in a tube. So let's look at a person. If you form an unwanted clot in your blood, and that clot moves to your brain, you have just had a stroke. If it moves to a coronary artery, you have just had a myocardial infarction, a heart attack. These unwanted clots are called thrombi. If they are free-flowing, that is, if they move through the bloodstream, we call them emboli. Singular would be thrombus and embolus. Now, an embolus doesn't have to be a thrombus. It can mean anything that's undissolved that's in the blood. So if you inject peanut butter into a vein, you would have a peanut butter embolus. Right? It simply means that something that's undissolved, that's in the blood. But typically it would be a thrombus. So we don't want people to form these unwanted clots. If we have reason to think that they're going to, we need to have drugs that we can give them to prevent the clots. Now, in a clinical setting, when the patient presents and we're worried about an unwanted clot, they can start an IV and they can give them heparin. And heparin inhibits the action of thrombin. Okay? But heparin has a very short life, so it's not a drug that you can send home with the patient. Right? They're going to receive this in an IV, and it inhibits thrombin. So it's a natural anticoagulant. If you want to do long-term treatment of the patient to prevent the clotting, very commonly they'll use vitamin K antagonists. Right? The vitamin K antagonists include a couple of drugs that have been around forever. There's newer ones, but these have been around forever. Dicumarol and Coumadin. Okay, so they stop the liver from using vitamin K. If you can't use vitamin K, you can't produce prothrombin. If you've heard somebody talking about that they're on a blood thinner, doesn't really thin the blood, right? But they call them blood thinners. They're taking probably one of these drugs or a similar drug, right? Dicumarol, Coumadin. Coumadin's very commonly used. Coumadin has another name. Coumadin is also called warfarin. Okay, so Coumadin is also called warfarin. Warfarin was used for many years as a rat poison. So they would put the warfarin in grain and leave it out for the rats to eat. Just like you and I, rats constantly form small leaks. And if they couldn't close those leaks off by forming a clot, the rat would die. After a while, the rats figured out, don't eat the grain that tastes like this, and so they quit using it as a rat poison, but it was around for a long time. So if a patient is taking a vitamin K antagonist, they want to make sure that they have the right levels of clotting, and so they'll very commonly do the INR, right, to check to make sure that they still clot normally and that they have adequate levels of prothrombin, not too high, not too low. Would it make sense that if somebody's on Coumadin, that they'd be concerned about them eating large quantities of green leafy vegetables?
Yes.
Make sense? Right? Because what's in large green vegetables? Vitamin K, right? Vitamin K, which would then interfere with their normal activity of their Coumadin. Okay, so this would be in vivo, right? So you're giving a person a drug. What about in vitro? If we collect blood from a patient and we want to run tests on it, whether they're going to check glucose or cholesterol or clotting, whatever they're going to check, if you put it in a glass tube, it's going to clot, and you're not going to be able to do the tests that you want to do. We don't want it to clot. So we make sure it doesn't clot by putting in a calcium chelator. Okay, we're going to put in a calcium chelator. To chelate means to act like a claw. And so calcium chelators grab onto calcium. And the calcium is no longer available for coagulation. Two very common calcium chelators are sodium citrate and EDTA. I'll tell you what EDTA stands for. You don't need to know it. It's ethylene diamine tetraacetic acid. EDTA is fine. So they will put these chemicals in the tubes. If you go in and get a blood test done, already in the tube that the phlebotomist is going to draw your blood into, there will be either EDTA or sodium citrate. Okay? So that it will tie up the calcium, the blood won't clot, they can do the tests that they want to do. Sodium citrate has the advantage, an advantage in that your liver can break sodium citrate down. So that if you go and donate blood, they're collecting a unit of blood in that nice bag, it will have sodium citrate in it so that the blood won't clot. But when they transfuse that into a patient, the blood is now available for the patient and the liver will break down the citrate so that the blood could still clot. You guys probably almost are getting young enough that you can't even remember this. But there was a famous football player named O.J. Simpson who killed his ex-wife. Do you guys all still remember this?
I thought he was found innocent. How can you say that?
He was found innocent. He was found innocent, but he was accused, let's say, alleged, if you will. During the course of the trial, they found, or when they went to investigate the crime scene, they found amounts of his blood at the crime scene, right? Which is pretty peculiar, right? His blood is at the crime scene. So when they had the trial, his defense attorneys wanted to try to get doubt into the jury, right? So they wanted to convince the jury that there was something else going on. And so they said, well, his blood was at the crime scene because when the police collected his blood, they went out to the crime scene and they dumped it around. Right? Well, if they collected his blood, they had to use an anticoagulant, and the anticoagulant that they use in their tubes is EDTA. And so if they doctored the crime scene, EDTA should have been present in the blood that was at the crime scene. Right? You following the logic here? Right? Well, there wasn't any EDTA in the blood that was at the crime scene. However, when EDTA breaks down over time, it leaves behind some residue, but that's found anyway. But they introduced and said, well, look, there wasn't any EDTA, but it's because it was at the crime scene for a long time, and so it was still EDTA. Of course, right, there were other things that led to his being freed on that one. They still got him on other problems in Las Vegas, right? Okay, anyway, kind of interesting. Transfusion.
Risk of getting a blood clot when you fly, like you're transitioning flight?
So the question is, why increase risk when you're on a long flight? And the reason there's an increased risk is really, well, it's kind of tied into the rest of the cardiovascular system that we're going to get, but it's really about sitting for too long of a time where blood flow back to the heart is limited. So by sitting there with your legs hanging down, over a long period of time, blood can tend to pool in the veins, and you end up with possible unwanted clots. We'll kind of get to that when we get to the cardiovascular system.